Thank you. Thank you. So, slight change of gear for today, because we've not really talked very much about old-fashioned examinations and whether or not they have a role. And this is the traditional form of examination. This is a picture which hangs in the college, and I was going to say that's probably Jonathan Beard there and Angus Wallace chairing the Court of Examiners at that time. And really this went pretty much rattled right the way through to the 1980s when I did my exams. It had very much this feel to it. And the other thing I'm going to touch on towards the end, which is selection, until very recently has felt like this. I had an interview for a chair of surgery at my own institution where I was interviewed by 28 people who were sat in a table which went away from me, not around like this, and at the very far end was the Vice-Chancellor, who was the only person who really asked any questions. So we'll touch a little bit on selection as well. So assessment systems for surgical training. The title of the symposium is around fitness for purpose. So I'm going to focus on examinations and whether they're fit for purpose. And I'm going to particularly focus on the role of the MRCS exam, not because I wouldn't like to speak about the FRCS, the exit exam as well, but there simply isn't time. So the exam I know most about is the MRCS. I was invited to get involved in the MRCS about 5 or 6 years ago now, when, with the advent of run-through training, the MRCS was going to be dropped. And if it was to be continued, it was recognised that it couldn't continue in its previous format, which was largely a combination of traditional structured or semi-structured vivas and short cases. And that was recognised, although it was recognised to be a relatively well-performing exam, it was certainly not performing as well as it could to meet the requirements of PMET-B at the time and now the GMC. We've seen this a lot. I think this process and the trauma and orthopedics process that was developed before it have really revolutionised surgical training, and I think, as Bill was saying, we're really only just getting used to it. And I think that when the use of workplace-based assessments is absolutely routine in daily practice, then we'll have got there and we'll have desensitised the whole thing so trainees don't feel they're being examined when in fact they're being formatively assessed. The nice thing about this and other similar surgical curricula around the world is that it gives you the opportunity to map them very clearly to the domains of your GMC, good medical practice, or whatever it is that your regulatory authorities in your country say. They all basically say the same thing. They talk about knowledge, clinical skills, professional behaviours. Certainly the feeling at the time when I first got involved was, because we introduced the concept of run-through training in this country, you could not have a summative assessment partway through that, where repeated failure of that assessment would result in your ejection from the training programme. And there was also a strong feeling that the purpose of the exam and its fitness for purpose was such that it could be replaced by workplace-based assessments. And I'm not even going to address that question now, because I don't think it's a relevant question in the setting where we are now, but that certainly was quite a strong feeling at that time. And the requirement was that if we were going to design an exam, it had better be more, if you like, fit for purpose, up to date. So I'm going to wait and see if my talk comes back now. My own experience of getting involved in assessments was based as an early career academic and missing a meeting, and that's that fatal thing when you miss a meeting, you get allocated a new task. And I got allocated the task of running the first OSCE exam in my university for finals, which was back in mid-90s really, and didn't really know much about it. And I was lucky to have a colleague who just arrived in Sheffield at that time called David Newble, who just arrived from Adelaide in Australia. And within 6 weeks we managed to put together a rehash of the previous summer's finals from Adelaide, and within a year or two that format of exam had replaced all of our other clinical finals examinations. And I must say, when I came to look at the MRCS, I was staggered at how far behind postgraduate surgical exams were. They hadn't really moved on very much for over many, many years compared to the speed with which undergraduate medical exams had moved forward and how much activity there was in the undergraduate world. And I think the postgraduate world, and particularly surgery, has caught up quite a lot over the last few years. I'm desperately treading water now.
The audience probably won't be able to hear me now, so you might have to repeat
the
question. It is jumping to the end of your talk, I think, and the use of MRCS
as
Okay.
one of the factors, one of the factors in selection.
We'll get going
back
on.
in business.
I'll jump to this because Bill showed this analogy as well. And I think it is, in some ways, quite a nice analogy. It's a vast oversimplification, but we know that for learning to drive, we have, if you like, a syllabus. Within that overall curriculum, there are very good learning aids, if you like, both for the knowledge test and also, very interestingly, if you look at this DVD, for the practical test, they do lots of simulated, you can do lots of simulated training for the driving test itself. And the question is whether or not this individual can sign off the learner just through 40 driving lessons and say, okay, I can sign you off now, you're good to go. The other question being, how come I'm paying for a driving instructor with a brand new BMW, but we'll leave that to another time. Or do you need the exam at the end of it to sign you off? What does the exam add to the judgment of an experienced, well-trained observer? And that's the dilemma we're facing in many ways. So the purpose of the MRCS is to check that trainees have acquired the skills and attributes for the end of early surgical training, currently called core training. And for those in the ISCP, it's a requirement to progress to higher speciality training. So it's a high-stakes assessment. The question I was just asked is whether it could have other purposes, a dual purpose. That used to be frowned on, the idea of a hidden syllabus or some kind of hidden agenda. But if it's explicit and out there, there's no reason why an assessment shouldn't be used for more than one purpose. So, is the MRCS fair? And in summative assessment terms, when we're talking about whether something's fair, and I apologise for the next few minutes for the educational experts in the audience, but I was working on the assumption that not everyone has this understanding and expertise. What we talk about when we're trying to work out if an exam is fair is whether it feels valid, whether it's reliable, and also, at a higher level, whether it has educational impact, whether it's cost-effective, whether it's acceptable to trainees, to assessors, to the public. And all these things come together to help you make a decision about whether an assessment is fair. So just looking quickly at the structure, there's fairly intensive 4 hours of multiple choice assessment, obviously assessing knowledge, both of the underpinning basic sciences, 135 single best answers, and also looking slightly more applied of principles in surgery in general, a mixture of SBAs and EMIs, which I recognise are becoming less fashionable than they were a few years ago. You have to pass Part A. You can have 6 attempts before passing Part B. You're almost getting to the random chance by your 6th attempt. And quite honestly, it's almost impossible to have 6 attempts at this exam and still be within the ISCP training programme. The second part of the exam tests applied knowledge and skills. And the applied knowledge component is that which can't easily be tested in written multiple choice exams. It's a fairly standard 20-station, 9 minutes plus 1 OSCE. The applied knowledge is around anatomy and surgical pathology, where we still use cadaver preparations, and also some applied surgical science, particularly in patient management, critical care. And these are very structured 10-minute vivas. In the clinical skills part of the exam, there's physical examination, as you'd expect, procedural skills, which is new and was controversial, particularly amongst surgeons who would say, surely these people can tie a knot, can do simple stitching, can demonstrate how to put a chest drain in. Surprisingly, that's not the case. And communication, 2 history taking and 2 more complex, challenging communication skills stations, either with a simulated patient or carer, or with phoning a senior colleague or some other form of colleague. So is it fit for purpose? Is it valid? Well, face validity is actually quite difficult to measure. Do people look at this exam and say, yes, that's testing what we need to test? Does it do what it says on the tin effectively? And some of that is what you get from feedback, and we get a huge amount of feedback after every sitting of the exam, and I was going to show you some of the comments because some of them are quite amusing, but basically we get feedback from the candidates, feedback from the examiners, feedback from the assessors, feedback from the lay examiners. But when you introduce something new, it's often a little bit unpopular, and we were talking earlier about how younger people are pushing for more modern things, but when we introduced this, the more junior trainees still quite like the old style exams that their consultants did. And one morning I went in to do my morning order and I asked my new SHO if he had done the MRCS, and he said, yes, Professor, I've done it. Sorry, just ignore that. But unfortunately I did the new Mickey Mouse version. So I explained to him that I'd spent the last 2 years working on getting that exam formatted, up and running and introducing, and I believe he's doing very well. I'm not sure where, but not very close to me. We need more GPs. So content validity, does it test a representative sample of subject matter? And those of you who are familiar with exams know this is all about matrices and blueprinting. So this is a blueprint from a recent diet. It's a big exam. There's often 500 or 600 candidates doing it at a time. It runs in 4 venues. It runs over 5 days. You end up with a large question bank, and you end up with these kind of matrices, these are all just codes for different stations. These are all analysed, so you can do all this standard item-by-item assessments of these stations and how they're performing and how they're contributing to the overall mark, the overall performance, the overall reliability. So it's possible with an exam which is structured, and this is where the word objective comes in, to do an awful lot of analysis, which you can't do in traditional style, fairly random clinical exams. You also blueprint the mark distribution across your domain. So we have this overall blueprint or matrix, which divides the exam into its component parts along the top. These are content areas, and maps the distribution of the marks down the vertical column to the domains that you want to test. So you can see clinical knowledge, clinical skills, professional behaviours. It gives you the ability to see what you're awarding marks for. The lilac and purple areas are for the applied knowledge in anatomy, pathology, critical care, and the larger areas are clinical skills and communication skills. And you'd be surprised at how much argument you can have about the distribution of these, the relevant distribution of these in a summative exam for someone who's only done 2 years of surgery, but you can spend a long time arguing about the distribution. Construct validity, does the exam support a sensible underpinning construct, which in English is do more knowledgeable or skilled candidates do better than less knowledgeable or skilled candidates. So it's very much what Bill was showing a minute ago with the more senior you get as an ST trainee, the better you do on workplace-based assessments. It's a similar sort of question. And in this you can see that, for instance, first-time takers, and particularly if they're in a recognised training post, do better than people who are resitting or people who are outside recognised training posts, such as F1 or F2 trainees who sometimes pitch up for this exam. Is it fair? For fair, you might as well say reliable in many ways. They're not quite interchangeable, but if an exam isn't reliable, then it will be perceived not to be fair. And reliable, you can always say, is it reproducible? Does it have internal reproducibility? An awful lot of emphasis was put on reliability of exams 10 years ago. Now it's very common to say that too much emphasis was put on reliability and people were chasing a metric, the Cronbach alpha, and just trying to push that up. And in order to chase that, they were sacrificing some of the more obvious things about face validity, content validity, having more and more stations because you could get a better reliability. But it still remains an important point. So the MRCS Part A gets the exact reliability coefficient that you would expect from a 4-hour multiple choice exam. You'd expect it to be over 0.9. That means it's effectively very reproducible. The OSCE exam, if you do this analysis on the whole exam, you join the whole thing together, you get a reliability score which is actually very respectable. It's over 0.8, it's about 0.85. We choose not to do that because the two components of the exam, the applied knowledge component and the clinical skills component, factor out differently. If you do a factor analysis, they're measuring different things, which is obvious. So you want to know that both components are independently have a reasonable degree of reliability. And the reason for that is that we require candidates to pass both components, both broad content areas, in one sitting without compensation, because they're testing different things. And you don't want people to be able to make up for a lack of knowledge by, for instance, being really good at communication. And you don't want vice versa. You don't want people who are terrible communicators to get through because they've learned the books. Standard setting is another important component of whether or not an exam feels fair. Candidates will often say, but I was only 2% below the pass mark. It can't be fair, the pass mark wasn't correct. So it's common with OSCEs, and I'm sure nearly everyone here has either done an OSCE or examined an OSCE. You have mark sheets. These mark sheets, being at a relatively senior level, are not tick box mark sheets, but they have an allocation of marks for specific components of the task with descriptors to guide the examiners and a supposedly independent global rating. And this is a template for a mark sheet. This is a lay examiner mark sheet for communication skills, so they get a proportion of the marks to award for the communication skills. The surgical examiner gets marks to award for the accuracy of the content of the information that's given. So you can see there are marks to award and a global score to fill in. And the standard we use, and again, apologies to those people who know this backwards, but it's of interest to people who don't or people who are about to do these kind of exams. You do have a check. It's not an itemized checklist, but there's a numerical mark that you achieve. You also complete a global rating. You then take the marks for all the candidates and plot them. So you plot the raw numerical score against the categorical score, the global rating, and you plot the curve, and you plot a regression line through it. And at the midpoint, where the line cuts the borderline group, is your raw score. And then most OSCE exams, or most exams of this nature, will add an element to that called the standard error of the measurement, or a multiple thereof, to allow for the uncertainty, if you like. It's similar to confidence intervals. So that's how the score is arrived at. There are different ways of doing this, contrasting groups or borderline group. The nice thing about this method is that it uses all the scores of all the candidates on all the items, and it can work well even when you've got relatively small cohorts. So that's why we've gone for that one in this particular exam. And when you explain that to people, it's a little bit complicated, but they say, okay, I can see how that works. It's not just a bunch of people sitting in a room saying, oh yeah, the pass mark is there, which is what it used to be in the old days. So it's reproducible, you can't really argue with it. Now, I'm just going to change gears slightly and talk about higher surgical recruitment, and I've got about 4 slides. So higher surgical recruitment, in the current situation, we have a national selection process for all 10 surgical specialities, and this is a slide I want to show, really. This has the content of selection across the top, and you'll see clinical stations, communication stations, and it has the different disciplines or sub-disciplines of surgery down the side, so you can see trauma and orthopedics, cardiothoracic urology. But if you look, they're nearly all testing some kind of clinical station, they're nearly all doing a communication skills station, they're nearly all doing a technical skills station. They'll only have one at the most, maybe 2 in those. It's never going to be able to achieve reliability on those, although there are novel approaches to looking at this. And in many ways, if you're doing this for higher surgical training selection, shortly after the MRCS, you're ignoring a vast amount of quite reliable data that you have on those candidates. So I would say that despite all these very appropriate approaches to increasing the reliability of national selection and to confirm its validity, it should be entirely possible to use elements of the MRCS to substitute for some of the steps in the multiple mini-interviews, such as clinical scores, communication skills scores, technical skills scores, and use the time freed up in the national selection process to do more useful things, like focus much more heavily on the individual's achievements through their portfolio assessment. And there's no reason not, in my view, to use the MRCS scores or the MRCS ranking or their decile, as we do for undergraduate assessment in selecting them for F1 posts. Sorry, this is still a bit slow. So just to conclude, I think that the whole of the summative assessment programme and the within the curriculum does comply with GMC best practice, and I think that its contribution to selection and also its contribution to predictive validity are areas for further exploration. Thank you very much.